talk about some very I'm going to talk about some very common hand conditions, conditions that you see every day, conditions that I see every day, some commonly missed hand and wrist conditions and so-called red flags. I'm going to mention the impact of COVID because we can't escape COVID. It's just there every day. And it's important that people understand what impact that has had on how we treat some of these hand conditions and so forth. And you might find that very reassuring, actually. So let's go through the common hand conditions. The common hand conditions are carpal tunnel, cubital tunnel, trigger digits, dupitrons, ganglia, de Quervain's, basal thumb arthritis. Those are conditions we see every day. You'll see them as much as I see them, probably. And the nerve compression, you may have come across the prioritization during the pandemic, during the first wave of the pandemic. The Royal College of Surgeons got together with other Royal Societies and came up with a prioritization process. We had to work out what was really important, what we had to do, what could be held off and so forth, what type of elective work should we be doing and not. So priority 1 and 2 are the urgent conditions. Those are the broken legs, the appendicitis, the patient needs a laparotomy and so forth. Those are urgent things, they've got to happen. Got to be looked after, or else the patient will come to some significant harm in terms of life or limb. Now, priority 2 conditions are conditions that can be deferred for about 4 weeks. And this will be some of the urgent cancers, and it will also include nerve compression, so which may well be a surprise to some people, but carpal tunnel and cubital tunnel and any other peripheral nerve compression is actually a priority 2 condition. So we ought to get on and treat those within 4 weeks. Trigger digits, dupitrons, ganglia, and so forth, those can all wait for at least 3 months, if not a bit longer. I'm a bit cautious to say they're priority 4 because some patients are significantly compromised by some of these conditions, particularly trigger digits, de Quervain's, basal thumb arthritis, and dupitrons. And I would say ganglia probably are a true P4 condition. Some of the red flags you come across in hand and wrist surgery, trauma, tumor, infection. We don't fortunately have lots of red flags, but probably the commonest red flags are the trauma type injuries that get missed from time to time. And absolutely top of the pile is scaphoid fractures. They do get missed. Missed FDP avulsions or tendon ruptures. Those are the so-called rugged jersey digits. I do see those missed all the time, and they're quite devastating. Scapholunate ligament injuries, they can be missed quite commonly too. Common cause of medico-legal complaints, and skier's thumb. And I'll just go through those very briefly a bit later on. The sort tumor, fortunately, is very rare in hand and wrist. We get some benign tumors like giant cell tumors; those are really common. And but very occasionally, I will come across something like a Panco's tumor, a sort of apical lung tumor, or cancerous lymphadenopathy. And the usual presentation of those is actually a nerve compression. If you see hundreds and hundreds of patients each year with some sort of numbness and tingling in the hand, every now and again, 1 or 2 of those will turn out to be a patient who's got proximal compression of the nerve at the level of the axilla or around the neck, and that will turn out to be a tumor or cancerous lymphadenopathy. You just need to be aware of that. Doesn't mean you suddenly need to be terribly paranoid, because it is still rare. But I would say in a year, I will see 1 or 2 patients who present like that. And so past medical history of cancer is really important, and knowing that the patient's under surveillance and so forth. Infection, again, infection is quite unusual. Tendon sheath infections do tend to happen. They can happen de novo after a rose thorn in the hand or some sort of dirty cut to the hand. And septic arthritis can happen also. Tendon sheath infection can be devastating. It could destroy the hand function completely. So it's a really important thing to be all over. It's infection of the lining of the tendon, and that can progress rapidly. It appears as a very, very painful digit, or a digit that the patient doesn't really want to move, and certainly not straighten. It can look swollen. And exquisitely tender when you palpate the tendon itself. And the threshold for sending those to A&E must be very low. Start them on antibiotics, get them into an ED or A&E very quickly. That's good. I do sometimes see TB risks because of where I work at St George's. TB is quite prevalent, and from time to time you will see TB presenting in the hand. Again, very rare, right? We'll see it at least once a year. And in fact, I recently saw it as a complication in a patient who had a wrist fracture, which was plated, and they had developed an infective complication around the plate, which turned out to be TB. Carpal tunnel, so back to the common everyday conditions. So the GPs will see, and physiotherapists and primary care healthcare professionals will see carpal tunnel. Patients will complain hopefully of mild symptoms. They will often describe nocturnal disturbance. So often patients will say, I'll wake up at night with numbness and tingling, or they might say, it's worse in the morning, and they might well describe some sleep disturbance. They wake up, shake the hand, and so forth. And that's not unusual. That's quite a common, fairly typical symptom. So we talked about red flags and how do you know it's not some horrible cancer in the axilla? Well, it's unlikely to be, but do ask about past medical history of cancers. Are they under surveillance? If you're concerned, examine their axilla, their armpit, to see if you can palpate anything. Sometimes these patients may present, the thing that might alert me to a red flag is if the patient presented with an extremely rapid history of neurological deficit, and also if it was a very dense neurological deficit. So if they came in with complete numbness, for example, and that's often how those types of proximal compressions present. Again, do beware, they're unusual. So to keep things in balance. Now, I don't know, some GPs seem to have access to nerve conduction studies and some don't. A lot of the physiotherapists do. Some of our hand therapists do seem to refer, and in the independent physios who are working, certainly have access to those. So I would say if you can get a nerve conduction study, do so. I always, as a matter of routine, will get a nerve conduction study, even when it's absolutely barn door for several reasons. So the times you want to refer up to the hospital for consideration of surgery is if the patient has got established neurological deficits. So if they've got numbness when you examine them, if they've lost their 2-point discrimination, if their dexterity is going away because they can't feel properly, and if they've got thenar wasting, that's certainly quite a late sign. We want to see those patients. I wouldn't really waste time giving those patients a splint. You can do it, but as long as it's at the same time as referring them up for consideration of surgery. These are the patients who often complain of constant paresthesia during the daytime as well. They're losing sleep, the function's compromised, dexterity is affected, and their activities of daily living are affected too. As I said, I always get nerve conduction studies, and at a show of hands at the British Hand Society a couple of years ago, the vast majority of hand surgeons said they do get nerve conduction studies. My rationale for it is it's an objective test that supports my threshold for taking a patient to theatre. I wouldn't take a patient to theatre without an X-ray if they had a broken wrist, and I would like to have some objective evidence that they have got carpal tunnel syndrome. So nerve conduction studies are really helpful. They confirm the diagnosis, and they can also alert you to double crush, where they might have compression proximally as well, which is not unusual. It's actually quite common. And it might give you an idea of prognosis. If the nerve test came back and said this patient's got very severe carpal tunnel syndrome, then that can allow you to counsel the patient and manage their expectations. That's really important. Another reason why I like nerve conduction studies is, let's say I did an operation on a patient based on clinical findings at all. Let's say they had very obvious rip-roaring carpal tunnel with positive T&O, positive phalans, and reduced sensation and so forth. And if I took them to theatre and decompressed them and they didn't get better, I wouldn't know whether is that they haven't improved because their condition was so severe and the nerve was so badly damaged in the first place, or was it carpal tunnel at all if they didn't improve? So, because some patients won't improve. If they're very advanced and they've got established neurological deficit, it can be difficult to reverse that. And then you're left with this awkward situation where the patient's had an operation and hasn't improved. Then that's, if you haven't got a test, an objective test confirming the diagnosis, that can be a bit awkward. And surgery is for patients who've failed non-operative measures like a splint, and perhaps a steroid injection, and patients who've got neurological deficit and those whose function is compromised. The role of a steroid injection for me is largely diagnostic. It's not an unusual situation to have a patient who comes and sees you and gives you an excellent history for carpal tunnel syndrome, and yet the nerve test comes back as either negative or showing only very mild carpal tunnel. In those situations, a steroid injection is quite helpful. It will confirm the diagnosis of carpal tunnel, and usually the effect of a steroid is quite temporizing. It may give them relief for a couple of months, and it might have a role in patients who don't want an operation, but arguably the steroid efficacy is as good as a splint. There are quite a lot of evidence to say a steroid is as effective for treatment as a splint. Here's some good evidence. This is a very new paper, very recent paper, only July this year, hot off the press. Ashley Blom, Professor of Orthopaedics in Bristol, looked at some common elective orthopaedic procedures and their clinical effectiveness and reviewed level 1 evidence. And he found that randomized controlled trial evidence supports carpal tunnel decompression and total knee replacement over non-operative treatment. These are two extremely effective operations, and that's really important. Dupuytren's disease, another common condition. We see various levels of it. The times I want to see patients is when they've got a contracture. So they need to be unable to get their hand flat on the table. And that's usually when the MCPJ and the PIPJ joints are contracted to about 30 degrees. That's the threshold for treatment. Those are in line with the ECI criteria and also in line with guidance from British Hand Society. I would, once they've got a contracture of that degree, 30 degrees, I would tend to advise you to refer them up to us reasonably early. And the reason for that is they may well be candidates for needle fasciotomy, which is a much less invasive procedure. Did it today, they're incredibly gratifying and means that the patient can avoid all the recovery that's associated with open fasciectomy. Previously, we were doing collagenase injections, Xiapex injections, and unfortunately, they've gone off the market at the moment. I've been involved in the DISC trial, which is Dupuytren's disease, comparing open surgery and Xiapex injections, and the results will be out hopefully sometime next year. I suspect, like in many of these pragmatic trials, they may not show a difference between open fasciectomy and Xiapex, and that might well prove some pressure for the companies to bring them back to the market, bring the Xiapex back to the market. I think it is quite a useful drug, and it's quite useful in certain situations, and I am quite a fan of them in the right patient, in the right situation. But it's a pity they're no longer available in the market. I'm hoping they'll come back, which is why I've mentioned them. Patients will often mention them to you as well because they'll read about them. Open fasciectomy is classical tried and tested surgery over many, many years. And this has some more risks compared to needle fasciotomy and Xiapex injections. And the recovery is greater, but we are cutting out all the disease that is macroscopically obvious. Sometimes patients will come to you mentioning radiotherapy, and overall, we don't tend to advise this. The fact that it's not available on the NHS tends to say something about its efficacy. There are several reasons why I'm not a fan of this, and most hand surgeons are not. And some of it relates to the damage it does to the skin in a patient. It makes it incredibly adherent and tight, and then surgery in the future is very challenging. I recently had a patient who had radiotherapy, and it does make the surgery much more technically demanding. Pitfalls around Dupuytren's, commonly mistaken for trigger finger. They are quite different, so the contracture is not correctable, whereas in trigger, the finger does correct. Sometimes patients are referred a bit later than we'd like. When they have finger and palm deformity, that really is a bit late. Splintage doesn't really tend to help. Splintage preoperatively is not particularly helpful. Trigger digits, these are really common and very straightforward. Lots of GPs, physios, hand therapists treat these really well in the community. The steroid injection is about 80% effective. Only a small minority of patients would require any further treatments. Some patients come back for a second injection, and that's really helpful. And then a minority would require open release. It really is quite unusual these days, and steroid injections are so effective. Other options are ultrasound guided needle release. Some of my radiology colleagues do that, but they often don't have the capacity. And splints, I don't find them particularly helpful. Patients don't usually wear them. They're cumbersome during the day. You know, it's a shame to splint them when we have quite a good treatment available by the way of steroid injections. Ganglia, very low threshold, very high threshold for treating these. Only for symptomatic, it's not for cosmesis. If the ganglion is very painful, or if it's traumatic in nature, atypical location, those are the ones that I would investigate and treat. The first line treatment for most of these is an aspiration, and it's got a 50% success rate, and there's some evidence that a second aspiration proves to be helpful still. Sometimes I'll inject them with steroid, particularly the very tiny ones that are difficult to aspirate. I would tend to inject some steroid into them, hopefully in a multipunctate manner, and disperse the ganglion. And surgery has I would say probably a 5 to 10% recurrence rate. And there is some evidence that you should try and avoid surgery for ganglia. So my threshold for operating on ganglia is very high. Other conditions that we mentioned earlier, de Quervain's, again, steroid injection is really successful for these, 80% success rate. Basal thumb arthritis, again, steroid injections. I tend to do these under image guidance. I think they're, for several reasons, partly because it's much easier than doing them in a busy clinic, much more accurate. And I think overall, it's a more positive experience for the patient because you can take the time to numb the area properly and target the joint specifically. And trapeziectomy is a tried and tested operation. It does involve fairly significant recovery, but it is a good procedure. And I would only do that in patients who've failed non-operative treatment. Cubital tunnel, like carpal tunnel, I always tend to get nerve conduction studies. I think there's not a lot of variation here. Most of us would get nerve conduction studies, and they often underestimate the problem. So the clinical symptoms and signs are really important for cubital tunnel. We're going to just move on to some of the more commonly missed injuries that I come across. Scaphoid fractures, as I mentioned earlier, scapholunate ligament injuries. So everyone's heard of the cruciate ligament of the knee, the ACL of the knee, but few people have heard of the scapholunate. And it is the equivalent of the ACL for the wrist. It takes load, it bears load. And if it's damaged, then the patient will get degenerative change, will get arthritis. Ruptured FDP, that's a closed injury to FDP. So if the patient presents to you with a laceration and knife cut on the hand and can't bend the finger, everyone assumes they've got a flexor tendon injury. But if it's a closed injury, if the patient's had a fall or they're playing rugby and an awkward pull, and there's no cut to see, people don't think of flexor tendon injuries, and yet they do occur, and they're quite commonly missed, and they are devastating. If they're not picked up early. Not being able to bend the tip of your finger is functionally extremely compromised, and it would stop me operating, and it stops power grip, so it really affects physical workers and people who type and so forth. It would affect most of us functionally, and if it's not picked up early, then you're looking at incredibly complex surgery, which is quite a big hit. Ulnar collateral ligament, skier's thumb, painful thumb after a fall. It's a skier's thumb till proven otherwise. These are, again, pretty important injuries not to miss, because the job of the ulnar collateral is to act to stabilize the thumb. The impact of these missed injuries is really can be quite devastating. Those 4 injuries I mentioned, they've all got reasonably straightforward treatments, some of which don't require surgery. And if they're picked up early, if we pick them up early, diagnose them and treat them either operatively or non-operatively, then you're avoiding the requirement for complex surgery. Because with complex surgery, the risk of surgical failure increases, recovery becomes more protracted, and the time off work increases, poorer outcomes, and they can be quite life-changing. And hands are pretty important for most of us, professional young people and physical laborers, and also, everybody needs their hands. They're really important. And what may seem a trivial thing can be life-changing for the patient. Here's a little algorithm for scaphoid fractures. I see at least 1 or 2 missed scaphoids every month, and all sorts of people miss scaphoid fractures. GPs, physiotherapists, surgeons, A&E doctors, all sorts of people miss them. So there's something about them that it makes them easy to miss. And that something is that the initial signs and symptoms, the initial presentation around a scaphoid fracture is often unimpressive. Sometimes the patient sits there and says, I think it's a sprained wrist, doctor. They can bend and move their wrist. There's not much swelling. There's not much bruising. And it looks like a sprained wrist. And that's why they get missed. They don't get investigated any further. So any fall onto an outstretched hand, or if they're a goalkeeper and high impact with a ball or something like that, I would say if they've presented to you, if they've come to you with wrist pain, that means they are symptomatic and they warrant at least an X-ray. And the X-ray of choice is a scaphoid views. NICE guidelines actually say the first line investigation, gold standard wise, is actually an MRI, but very few people can obtain that, can achieve that standard. I certainly can't, where I work in a busy trauma center, and I don't think many people can. It's quite unusual. So these patients require a scaphoid X-ray. If the scaphoid X-ray is negative, then that does not exclude a scaphoid fracture. Because we know that 25% of scaphoid fractures are not visible on the first X-rays. So those patients should be referred, if they've got ongoing pain, they should be referred to the hand clinic or a fracture clinic. They should be, in the meantime, they should be splinted, either in a Futura splint and advised not to take it off, or into some sort of plaster. Until the diagnosis is either excluded or confirmed. There are 2 ways of confirming. One is an MRI scan, and many of my patients do get an MRI scan eventually. And some of the patients the scaphoid fracture will be obvious at the 2-week X-ray. So that's well worth doing, particularly if you don't have access to MRI scanning. Once you've confirmed a scaphoid fracture, some will fix, like proximal pole fractures or ones that are unstable or displaced, but the vast majority of scaphoid fractures can be treated in a plaster uneventfully. So it's such a shame to miss these because these are injuries that could have been treated without surgery the majority of the time if picked up. Only last week, I had a 12 or 13-year-old boy come to the clinic with a missed scaphoid fracture. Seemed to be seeing younger patients. It's unusual to see that age group, and they would always heal. A child with a scaphoid fracture would nearly always heal if treated appropriately, if you put them in a plaster early on. If they're not diagnosed and they're not picked up, then they won't heal. So this boy I'm talking about will now look at surgery, which is a highly unusual thing for a child with a scaphoid fracture. Scapholunate ligament injuries, we see them in adults, and they are a cause for some medico-legal concern. These are the load-bearing important ligaments. The reason they're important is if they're missed, patients can develop premature arthritis. If we pick them up early, which we often do not do, then they can have an early repair. And if they're picked up late, they're looking at rather more complex surgery, sort of reconstructive type procedures. And the common end of the road sort of destination for missed scaphoid injuries and missed scapholunate ligament injuries is arthritis. So they get the progressive traumatic degenerative change around the carpus, and they're called so-called SNAC or slack wrist, scaphoid non-union advanced collapse, or scapholunate ligament advanced collapse. And then they're looking at salvage procedures like proximal row carpectomy. These are quite complex operations, and ultimately total wrist fusion. In some cases, it may be appropriate to do a total wrist replacement. So skier's thumb, this is the ruptured ulnar collateral ligament. The ulnar collateral ligament is a stabilizer of the thumb, and the thumb needs to be nice and stable so you can push against it, so that you can do pinch, grip, key pinch, grip. You can't do that properly, and your dexterity would decrease if the ulnar collateral ligament wasn't working. Ulnar collateral ligament, you want to pick it up early. Ultrasound scan is a really good way of diagnosing it. X-rays will sometimes show an avulsed bony fragment, and that can be diagnostic. And some of these patients are suitable for surgery. Many can be treated in a splint. It's well worth picking these up as a diagnosis. So anybody with a fall and a painful thumb with tenderness on the ulnar side of the metacarpophalangeal joint, think ulnar collateral ligaments. And as I say, surgical treatment's actually fairly straightforward when picked up early. We simply reattach, and patients tend to recover quite well. If they're missed, then they're looking at rather more complex surgery by the way of tendon graft, reconstruction, greater surgical risk, more stiffness, and probably poorer outcomes compared to early repair. And the same principles apply to rug or jersey. These are the missed FDP flexor tendon injuries. In this picture, you can see that the patient cannot flex the tip of his finger, and that will affect his dexterity. We quite commonly see it when patients can fall. If they fall on an outstretch, sometimes they can't, they can sustain a ruptured or avulsed injury. And classically, it's in rugby when forced hyperextension of a flexed finger, usually when the patient is pulling, when the rugby player is pulling the opponent's shirt, this can happen. And the ring finger is most commonly affected. So hands are really important. They're important for communication, grasping, touch and feeling. They're culturally really important. If you see abnormalities of the hand, in some cultures that can be quite stigmatized. So they're really important. People look at people's hands all the time. They are important. In the olden days, when I was a registrar, I remember they were kind of a poor cousin, and really, this was, we've really moved away from that. We have lots of specialist hand and wrist surgeons in almost all hospitals now. So access to expert care is really readily available. Impact of COVID, worth saying, because some people might think, oh, it's only a hand, let's not get this done, not worth it, too high risk, we've got COVID knocking around. Well, actually, some of the conditions are priority too, so we ought to get them done within 4 weeks. That's the Royal College of Surgeons guidance. Many of these procedures are done under regional anaesthetic or local anaesthetic, so not general, and that's lower risk because general anaesthetic is aerosol generating. So that's a really good thing. The fact that we can operate on these, some high-risk patients, wide awake surgery, not putting them to sleep, makes it really safe. Regional anaesthetic techniques are now excellent. They're widely available in all hospitals. It's not new, it's not magic, it's not unusual. It's really quite commonplace, and it allows us to operate on high-risk patients. There's day surgical, so green site surgery lends itself really well to that. We can get patients in and out on the same day. That makes it COVID light and COVID secure as much as we can. And it's really important because it means that patients are not coming anywhere near our acute main hospital sites where we do have other amber pathways and so forth, patients with COVID, patients with possible COVID, unknown status. We can get these patients done on green standalone sites, most day surgical units. It's really pretty straightforward. The hand surgery tends to be a small physiological insult to the body compared to, let's say, doing a hip replacement or doing a laparotomy. This is relatively lower physiological insult for the patient. So even if they did have COVID, if they required their wrist to be fixed, all is possible with appropriate consent and patient permission. Testing and vaccines obviously have made a massive impact. The vaccine is very protective, although it doesn't stop you getting COVID. As we're discovering now, it does protect patients in terms of getting milder disease most of the time. And most of our surgical patients, fortunately, are now doubly vaccinated, which makes a big difference. Testing has been hugely helpful and has allowed us to test staff, test patients, make our surgical pathways as COVID secure as possible. That's been incredibly important. So summarizing, diagnose some of these conditions that we talked about, the red flag conditions, the missed injuries early. Treatment options are the possibility of less intervention is possible if you diagnose earlier, and we can avoid complex surgery, protracted rehab, and so forth. And getting these patients treated means that we can make a significant impact on their economic and sporting status. So concluding, we've talked about the common hand conditions, the thresholds for referral, and a lot of these things can be treated in the community very safely with splints, anti-inflammatories, steroid injections, and so forth. We've talked about the criteria for surgery, the impact of delay, the red flags we've been through, and we've also talked about the impact of COVID and how this hasn't really stopped us operating and treating hands where necessary. Thank you very much indeed.
Thank you very much. Brilliant, thank you. There's 2 questions so far in the questions and answers. You can feel free to post any of your questions, either in the chat function or the question and answers function. We've got one from Susan with carpal tunnel syndrome. Is it P2 only the severe as per nerve conduction studies as opposed to mild or moderate? I think that's regarding referral to secondary care.
Yeah, so no, I think what they're referring to is the Royal College of Surgeons prioritization. So that really refers to patients who are already on the waiting list. Now, fortunately, orthopedics has been ahead of the curve, and much of what's come out in COVID, we've already been practicing. So we've already been only putting patients on operating lists once they meet certain criteria. And I would be focused on the symptoms, whether they've got neurological deficits, and whether it affects their function, and have they tried splints and perhaps steroid injections. Once they meet the criteria for surgery, they go on the operating list. So anybody on the operating list automatically becomes priority 2. So so it's really a surgical decision as to whether a condition is priority 2. So the condition is priority 2, and they only go on the operating list once they meet those ECI criteria. So, you know, from a referrer's perspective, you don't really need to worry about the prioritization. What you should be asking yourself is, does this patient meet the criteria for surgery? That's what you should be asking yourself. Does that make sense?
Great, thank you. There's a question from Dan. How would a scapholunate injury present, mechanism of injury, and what clinical tests would be helpful to identify this injury?
That's a great question, because this is a commonly missed problem. So any patient who has a fall onto an outstretched hand and they've got central wrist pain, they can't load it. A young man will often say something like, I can't do press-ups, I can't lift something heavy, I can't do stuff in the gym that I usually can do. That's the sort of thing they will say. And then when you examine them, they're tender in the central aspect of the wrist on the back of the hand. And there is a test called Kirk-Watson's test, which is a really specialist test. And I wouldn't expect all, I wouldn't expect non-specialists to be super aware of how to do that. It is a real expert test, and it involves trying to palpate to see whether the scaphoid subluxes when the wrist is pushed into radial deviation. So that's something that you would really expect somebody who's used to doing that test every single day to pick up. So the history is more important for most referrers. Any patient who's had a fall onto an outstretched hand, often during sport, but not exclusively, and they've got central wrist pain, normalish x-rays usually, those are patients we should be thinking about scapholunate ligament injuries, and we should be thinking about scanning them, doing MRI scanning. They're difficult to pick up, but if you think about it, you're more likely to pick it up. You're on mute.
Oh, sorry. Dan said, thank you. I don't have any other questions so far.
Okay.
Are there any other questions? Or otherwise, everyone can go and enjoy the warm evening. No, I don't think so. Thank you very much, Mr. Umarji. We really appreciate it. It's been a brilliant presentation. And I hope you guys all enjoy your evening. Thank you, everyone.
Thanks very much indeed for having me. All the best. Bye-bye.
Take care. Bye-bye.
Bye.